Pleural effusion is accumulation of fluid in pleural cavity. Now look at the normal anatomy of lungs. This is these are the lungs and these are covered by pleura. So there are two types of the pleura. One is parietal pleura and another is visceral pleura. And the space between two pleura is pleural cavity. Now, when accumulation of fluid occurs between these two pleura is known as pleural effusion. So, the effusion is accumulation of fluid in pleural cavity, and that fluid may be transutative or exudative. So, the difference between transutative and exudative pleural effusion is in transutative pleural effusion, protein is less than 3 gram per deciliter, and LDH activity is less than 200 IU. And the causes of transudate pleural effusion are heart failure, nephrotic syndrome, constrictive pericarditis. So these are three important causes of transudate pleural effusion. While exudative pleural effusion has protein more than 3 gram per deciliter and LDH lactate dehydrogenase activity is more than 200 IU per liter, and the causes of exudative pleural effusion are bacterial pneumonia, TB, and malignancy. So, the transudative pleural effusion has heart failure, nephrotic syndrome, and constrictive pericarditis, while exudative has bacterial pneumonia, TB, and malignancy. So, these are prominent causes of pleural effusion. Now, clinical features of pleural effusion are dyspnea, cough, shortness of breath, and there will be decrease or inaudible breath sound with a dull sound percussion, and mediastinum will shift shift to the opposite to the affected lung, and X-ray show lateral decubitus view shows homogeneous opacity that obscure the underlying lung. Pleural fluid aspiration should be done for microscopy and culture, and pleural biopsy is also performed in pleural effusion. Now, the treatment for pleural effusion will be antibiotic for bacterial cause, anti-TB drugs for tuberculous cause of the effusion. If large effusion is there, then chest tube insertion should be done. Now, as you can see, this is X-ray of pleural effusion patient, and in order to interpret x-ray we have to look at the AP view and PA view, and this is right side, this is left side of the lung, and as you can see the trachea is shifted opposite, and the homogeneous opacity present here. So the as you can see in the pleural effusion, there is accumulation of the fluid, and fluid is settled here down, and dark shadow is here in the upward position. So in pleural effusion, this downward descent of fluid has remarkable sign on the X-ray, and this is pleural effusion of the right side of the lung. So in this way we can interpret the X-ray, and we can look for the pleural effusion. Simply, the treatment for pleural effusion for bacterial cause antibiotics, and for TB anti-tubercular drugs should be given, and if there is large effusion then drainage should be done. Pneumothorax is defined as accumulation of extrapulmonary air in the chest. There are different causes of pneumothorax like spontaneous pneumothorax, traumatic pneumothorax, and iatrogenic pneumothorax. Now, the spontaneous pneumothorax has primary spontaneous pneumothorax and secondary spontaneous pneumothorax. In primary spontaneous pneumothorax, it occurs with the trauma, and secondary spontaneous pneumothorax occurs as the complication of any lung disorder. So, in this way, pneumothorax develops, and the clinical feature for the pneumothorax are shortness of breath, decreased breath sound on affected side, and decreased vocal firmness will be there. trachea will be shifted away from the affected lung, and it indicates the tension pneumothorax when trachea is shifted away from affected lung. Now, as you can see, this is the normal lung, and trachea is present here. When pneumothorax means accumulation of air occurred in this right side of the lung, then the trachea will be shifted away here in opposite side of the affected lung. So this will indicate the tension pneumothorax, means trachea is affected opposite side and air is accumulated in right side of the affected lung. Now the diagnosis for this pneumothorax will be chest X-ray, CT chest for small pneumothorax or blebs. And the treatment for pneumothorax is antibiotic. For small asymptomatic pneumothorax, no treatment is required. And if there is large pneumothorax, then needle decompression should be done, and tube thoracostomy is performed. Tube thoracostomy is definitive treatment in which insertion of tube at fourth, fifth, and sixth intercostal space at mid-axillary line is done, which connected to the water seal device. So in this way we can relieve pneumothorax. Now this is X-ray of the patient. As you can see, this is right side of the lung and this is left side of the lung. So right side of the lung is showing the black shadow because of air accumulation. So this condition is right side pneumothorax, tension pneumothorax, and as you can see, the trachea has been shifted opposite to the affected lung, means this is tension pneumothorax. So in this way, this tension pneumothorax is present on the X-ray, and how we will treat this patient, we will give antibiotics, and we will also perform needle decompression of this pneumothorax, and in this way we can relieve the patient from the disease. Okay, so the asthma is chronic disorder of airway characterized by reversible airway obstruction, inflammation, and bronchial hyperresponsiveness. Now we will look at the triggering factors which can aggravate the asthma. So triggering factors of asthma are respiratory infection, exercise, cold air, emotions, allergens, gastroesophageal reflux, and exposure to pollutants. In this way, asthma can be aggravated. Types of asthma are intrinsic and extrinsic asthma. Intrinsic asthma has no evidence of IgE involvement, and it is seen in first 2 years of life with uncommon family history, while extrinsic asthma are also known as allergic asthma, has increased concentration of IgE antibody, and family history is common. So the clinical features of asthma are cough, wheeze, difficulty in breathing, nasal flaring will be there, resonant percussion note with reduced air entry. Chronic asthma shows the barrel-shaped chest, and sternum may become prominent, and Harrison sulci is there in the asthma. So the diagnosis for the asthma is clinical based on history and examination. Chest X-ray shows peribronchial thickening, subsegmental atelectasis, and hyperinflation. Pulmonary function test will show decreased FEV volume and decreased vital capacity with increased residual volume and increased total lung capacity. So causes of asthma as we discussed, and now we will be looking at the category of asthma management. So there are different strategies for the management of the asthma. On the basis of clinical characteristics, we will manage the asthma. If there are daytime symptoms and night symptoms greater or less than 2 weeks, we will treat the asthma on that basis. So the general management for asthma will be a short-acting inhaled beta agonist for symptomatic relief, and
Also, low dose inhaled corticosteroids should be given, and medium dose inhaled corticosteroids. In this way, we can manage the asthma by also giving long acting beta agonist corticosteroids and bronchodilators. So, in acute asthma treatment will be nebulization of salbutamol, and hydrocortisone should be given, and betamethasone is also given. For status asthmaticus, there should be salbutamol with ipratropium nebulization is also given. And in chronic asthma, a patient should have the measures and the control of the environment, and asthma severity should be monitored with beta 2 agonist, theophylline, ipratropium, leukotrienes antagonist should be given. So in this way, asthma can be treated by this medication. Now, as you can see in this X-ray, there is hyperresponsiveness of the lung, and asthma X-ray typical view is shown.